We're talking about the great vessels, and our mission is, well, it's pretty ambitious. We want to give you, the listener, a thorough, structured, and profoundly detailed understanding of the heart's immediate neighbors.
The arteries and veins right next door.
Yes, the pulmonary trunk, the aorta, the brachiocephalic veins, and of course the superior and inferior vena cava. And we are going beyond just listing facts. We want to unpack the precise dimensions, the specific branches, and the crucial anatomical neighbors of these vessels.
These vessels are the absolute core of the circulatory system. Understanding their precise location down to the centimeter, down to the vertebral level, it's not just academic trivia.
No, not at all.
It is critical to understanding normal cardiac function and, maybe more importantly, how rapidly pathology in this region can become catastrophic, life-threatening.
So we're looking for the why behind the placement.
That's it. Why is this vessel here? What is it constrained by? Precision is the name of the game today, and we are going to explore the nuances of every line item in the sources.
Okay, let's unpack this detailed blueprint. We're going to start with the outbound flow to the lungs, the pulmonary trunk.
Perfect place to start.
So when most people think of arteries, they immediately picture oxygen-rich, bright red blood being pumped out to the body. But this vessel, the pulmonary trunk, is the major functional exception to that rule.
A huge exception.
It's the beginning of the lesser, or pulmonary, circulation. It's the only major artery carrying deoxygenated blood traveling from the powerful right ventricle toward the lungs to, well, reload.
And what's absolutely fascinating here is the trade-off you see between its length and its diameter. Our sources really emphasize this. The pulmonary trunk is built for speed and for volume, not for distance in the chest.
Okay, so it's a short sprint, not a marathon.
Exactly. It's quite short, typically measuring only about 5 centimeters in length. But,
Right.
and this is the key, it's remarkably wide, around 3 centimeters in diameter.
5 by 3, so it's short and very, very stout.
It is. And that shortness and width are critical to maintaining the lower pressure required by the delicate pulmonary capillary beds in the lungs. If it were long and narrow, the resistance would just skyrocket.
So it's a massive short tunnel designed specifically to minimize resistance. And, crucially, it has a defining spatial relationship right at the very start.
It does. Anatomically speaking, the pulmonary trunk is the single most anterior of all the great cardiac vessels.
The most anterior, so it's front and center.
Absolutely. If you look at the heart in 3 dimensions, the pulmonary trunk essentially hides the ascending aorta from the front. This anterior placement is vital information for surgeons and, for radiologists looking at an angiogram or performing any kind of interventional procedure.
That anterior placement, which you can see really clearly in the diagrams we're looking at, it immediately gives us context for its relationship with the sternum and the chest wall.
Mm-hmm.
Now let's track its launch. Where does this massive short vessel actually spring from?
It arises directly from the outlet chamber of the right ventricle, and this origin is specifically marked by the pulmonary annulus, which is a fibrous ring surrounding the subpulmonary canalus arteriosus.
Okay, canalus arteriosus. Let's break that down.
It's just the anatomical term for the infundibulum. Think of it as the funnel-shaped outflow tract at the base of the right ventricle.
So it's not just popping off the ventricle wall, it's launching from a dedicated funnel-shaped ramp.
Exactly right. And from that origin, its course is superior and distinctly to the left, rising superior to a structure called the supraventricular crest.
And that crest is the ridge that separates the inflow and outflow of the right ventricle, correct?
That's the one. This specific upward and leftward trajectory is key because it immediately starts to wrap around the ascending aorta, initiating this complex, almost spiral relationship between the 2 major vessels.
And the whole life mission of the pulmonary trunk is achieved at its crucial bifurcation, the immediate split, where it divides to serve both the right and left lungs.
Right.
Given how short the vessel is, this split must happen almost immediately after it leaves the heart. Where exactly is this anatomical landmark?
This is one of the most precise landmarks in the entire thorax. The division, the bifurcation, it occurs approximately at the level of the body of the 5th thoracic vertebra, T5.
T5, that's interesting, because that level aligns roughly with the thoracic plane, which is defined by the sternal angle, the junction between the manubrium and the sternal body.
It does, but there's a slight distinction.
Ah, okay. Remember, the sternal angle marks the T4-T5 disc level. So if the aortic arch is at T4-T5, the pulmonary trunk bifurcation is almost directly adjacent, but just a little bit lower.
That's exactly right. Our sources specify that the bifurcation point is actually 2 to 3 centimeters inferior to the sternal angle,
Okay, so just below it.
just below it. And the split itself typically creates the right and left pulmonary arteries, which are often described as being of almost equal size, and they head off immediately toward their respective lung hela.
So we have this rapid, forceful output from the right ventricle, short, wide, minimizing resistance, and it makes a quick split just below that major T4, T5 anatomical plane.
Mm.
Let's talk about its neighbors. How is this dynamic structure connected or sort of tethered to the rest of the chest cavity?
Well, the pulmonary trunk and its infundibulum of origin are not just free-floating. They are commonly anchored or tied antero-inferiorly to the left side of the pericardial reflection.
And what's doing the anchoring?
This anchoring is mediated by the associated lymph nodes, specifically the subpulmonary or inferior tracheobronchial lymph nodes, and it also incorporates fibers from the deep cardiac plexus.
That anchoring via the lymph nodes and nerve plexus? That's powerful synthesis. It explains why, say, a severe infection or a malignancy leading to swollen lymph nodes in that specific area could physically pull on or even distort the pulmonary outflow tract.
Exactly. Even if the nodes aren't touching the vessel wall directly, that tethering can cause a functional impairment. It's a physical connection we have to be aware of when we're studying pathology.
And we can't really discuss the pulmonary trunk without mentioning its fetal connection.
The ductus arteriosus, yes.
In the fetus, the pulmonary trunk is functionally linked to the aortic arch by this ductus, which shunts blood away from the non-functional lungs.
And this ductus closes, it obliterates shortly after birth, remaining in the adult as a fibrous band called the ligamentum arteriosum.
It's amazing that this little remnant is so powerful. It's not just some historical curiosity. It is one of the most clinically relevant structural tethers in the entire adult chest.
100%. That ligamentous connection links the pulmonary trunk directly to the underside of the aortic arch. We're going to see later that this fixation point is frequently cited in clinical contexts, particularly in relation to the stability and the vulnerability of the aorta during trauma.
A point of structural weakness created by a remnant of fetal necessity. That's fascinating.
It is.
So if the pulmonary trunk is the low-pressure, high-volume artery for the lesser circulation, now we need to transition to the highest pressure highway in the entire body, the aorta.
The big one.
The big one. We're now moving to the high-pressure systemic side of the highway. The aorta is, well, it's arguably the single most vital vessel. It's the grand central artery, and we have to break down its thoracic course into its three distinct and highly specialized segments.
Ascending, arch, and descending.
Let's start with the ascending aorta, the launch pad.
This is where systemic circulation begins, which makes it the highest pressure zone in the entire system. It has to accommodate the enormous systolic force generated by the left ventricle.
And like its neighbor, the pulmonary trunk, it's relatively short.
It is, typically about 5 centimeters in length.
Our sources map its origin pretty precisely. It begins superiorly to the left ventricle, immediately behind the sternal end of the third costal cartilage. But it's not a straight vertical shot up, is it?
No, not at all. Its initial course is quite complex, which is critical for understanding its relationships. It initially ascends superiorly, anteriorly, and to the right.
Up, forward, and right.
That slight curving trajectory is what allows it to quickly emerge from behind the pulmonary trunk, establishing its position in the upper mediastinum.
That sounds like a highly dynamic pathway right through the center of the chest. Let's trace where it goes. What structures is it running behind?
Because of that initial anterior and rightward vector, its course through the thorax takes it posterior to the left half of the sternum and posterior to the manubrium. It also runs posterior to the pericardium itself, and even posterior to the right lung and the right atrial appendage.
So it has extensive critical relationships with nearly every structure in the anterior mediastinum.
It really does. Its boundaries extend along the left side of the sternum from the third costal space all the way up to the superior border of the manubrium.
This complexity begs the question, what is its intimate relationship with the heart structure itself?
Here's where we synthesize the anatomy with the physiology. The ascending aorta is enclosed in a tube of serous pericardium, which it shares with the pulmonary trunk.
It shares the pericardial sleeve.
It does, which means that functionally and structurally, this specific 5-centimeter segment of the aorta is essentially part of the heart. It sits within that fibrous sac.
So any pathology here, say, an acute aortic root dilation or an aneurysm, instantly affects the pericardial space, and thus the functional integrity of the heart itself.
Exactly. It's entirely different from the arch or the descending aorta, which sit outside that protective bubble.
That is a huge flag when considering trauma or rupture. It's a critical anatomical detail.
Absolutely. And this segment terminates just as specifically as it begins. It ends behind the junction of the manubrium and sternum, that critical anatomical plane we call the sternal angle.
Which, again, aligns with the T4-T5 intervertebral disc.
Precisely. And that marks the immediate, sharp transition to the next segment, the arch.
So we leave the ascending segment and we enter the great curve, the aortic arch. This is the anatomical masterpiece that has to turn the highest pressure traffic flow a full 180 degrees.
Right, allowing distribution to the upper body and then sending the main trunk downwards.
It launches from behind the lower mediastinum at that same sternal angle landmark, the T4-T5 level. But its trajectory is arguably its most critical feature.
It is. It initially ascends superiorly and posteriorly, creating that perfect arch shape. But the key is what it passes over. It crucially arches directly over the root of the left lung.
Specifically tenting over the left primary bronchus.
Yes. That non-negotiable relationship arching over the left lung root is what defines the entire anatomy of the left pulmonary hilum.
Oh.
You got this massive artery sitting right on top of the air intake pipe for the entire left lung.
It's an incredible image.
And structurally, the arch is surprisingly tight. Its summit, the highest point of the curve, reaches about 2.5 centimeters inferior to the jugular notch.
And if we connect this to the bigger picture of the spine, the arch continues as the descending thoracic aorta when it reaches the superior border of the fourth thoracic vertebra, T4.
That's right.
So that confirms the tight geometry. The entire curve from the T4-T5 disc level down to the superior border at T4 is highly concentrated. It's not some lazy long curve.
No, it's a tight, focused anatomical centerpiece, which makes its relationships even more dense and critical.
Let's delve into those anatomical relationships, what our outline calls the web of life. Because the arch is surrounded by structures that, if damaged, have huge systemic consequences.
Let's start with the structures lying anteriorly and to the left of the arch. You have the left lung and pleura, the remnant of the thymus gland, the left phrenic nerve, and the left cardiac branches of the vagus nerve.
So a whole cluster of nerves and organs right there.
Yes, and that cluster highlights the extensive reach of the arch's pressure wave and just how dense the superior mediastinum really is.
And what runs posterior to it and to the right, sort of hidden from the front view?
Posteriorly and to the right, we find the primary conduits of the superior mediastinum, the trachea, the esophagus, the deep cardiac plexus, and critically, the left recurrent laryngeal nerve. The thoracic duct also passes posteriorly.
Okay, let's focus on that nerve, the left recurrent laryngeal nerve. This nerve is intimately related to the aorta in a way that the right side is not.
It is intensely important. The left recurrent laryngeal nerve, which controls nearly all the intrinsic muscles of your voice box, originates from the vagus nerve high up in the chest, but then it takes this bizarre detour.
It hooks, right?
It hooks right under the aortic arch before ascending all the way back up to the larynx.
That journey seems unnecessarily complicated. Why the hook?
It's an embryological remnant. In our fish ancestors, this nerve hooked under the sixth branchial arch artery. As we evolved, the arterial anatomy changed, but the nerve kept its original path around the retained arterial structure.
Which in this case is the distal part of the aortic arch, near the ligamentum arteriosum.
Exactly. So the key takeaway for you, the listener, is that if you have any pathology, say a significant aortic aneurysm or a dilatation of the arch, you have to check the voice.
Because that nerve is literally pinned underneath that expanding structure.
Precisely. Compression or irritation of that nerve can lead to vocal cord paralysis, which manifests as hoarseness. It's a clinical finding classically associated with aortic arch pathology, sometimes called Ortner's syndrome.
That is a stunning example of how deep anatomy connects directly to simple clinical science.
It really is.
Now let's talk about the outflow. Before we leave the arch, we have to look at those three major distribution points, the big three branches. What's the typical sequence as they spring from the top of the arch?
They arise sequentially in this order. First, the brachiocephalic trunk. Second, the left common carotid artery. And third, the left subclavian artery.
And together, they distribute blood to the upper limbs, the head, and the neck.
That's right.
But anatomy is rarely uniform, and our sources emphasize that we have to delve into the variations. Are variations to this standard trifurcation common? And what are the implications?
They are common and they are extremely important, especially in the context of cardiovascular surgery or intervention. Our sources note several variations exist. For instance, you might see the absence of the brachiocephalic trunk entirely.
Meaning the right common carotid and right subclavian arteries would just arise independently from the arch.
Correct. But the most common anatomical variant is the so-called bovine arch.
The bovine arch, what does that look like?
Instead of three separate arteries, you see a common trunk for both the brachiocephalic trunk, which supplies the right side, and the left common carotid artery.
So 2 branches instead of 3.
Essentially, yes. This configuration, found in a significant portion of the population, often necessitates alternative strategies during aortic surgery or when attempting catheterization because the angles of approach are just dramatically altered. The surgeon absolutely needs to know if they're dealing with 3 points of origin or just 2.
Okay, now let's dive into the surprising deviations from the norm and the clinical dangers associated with this high-pressure curve. Beyond those typical variations, what congenital anomalies are mentioned in our material?
The congenital anomalies can range from those that dramatically alter circulation to those that cause structural compression. One of the most notable is a double aortic arch.
A double arch.
Yes, where embryonic structures persist, effectively creating a ring of arterial tissue that completely encircles and can potentially compress the trachea and the esophagus.
Often causing breathing and swallowing difficulties, especially in infants.
Exactly. And for those who interpret imaging, there's a crucial landmark related to the arch and the pulmonary trunk, the aortopulmonary window.
Let's use an analogy to help visualize this space.
Think of it like a small room. The ascending aorta is the right wall, the pulmonary trunk is the floor, and the aortic arch is the roof. The descending aorta then forms the left wall.
Okay, so it's this little enclosed space, the aortopulmonary window. It's a pocket of connective tissue and lymph nodes.
Yes. And why that tiny pocket is so vital clinically, as you'd see on a posterior anterior chest x-ray or a CT scan, is because this window is a primary location for observing lymphadenopathy.
Enlarged lymph nodes.
Right. The lymph nodes here are crucial links in the tracheobronchial chain. So if a patient has a malignancy, like lung cancer, enlargement of these specific nodes, which is clearly visible in the aortopulmonary window, helps determine the extent of mediastinal involvement. It guides staging, diagnosis, and treatment.
So the size and shape of this window are constantly monitored. Now, moving from chronic conditions to acute emergencies, aortic dissection. We mentioned this is an event with extremely high mortality, 30 to 40%, even with immediate treatment. Let's expand on why it so often originates near the ligamentum arteriosum.
This all boils down to biomechanics. An aortic dissection involves a tear in the innermost layer, the intima, allowing blood pressure to split the layers of the arterial wall.
And it starts near that ligamentum.
Very often, yes, because that is a fixed point. When the body, particularly in a deceleration injury like a car crash, stops suddenly, the heart and the ascending aorta encased in the pericardium are relatively mobile, but the descending aorta is relatively fixed by the structures along the spine.
So if the chest wall stops suddenly, the mobile segment tries to keep moving while the fixed segment holds fast.
Exactly. This creates massive shear stress at that point of attachment, the ligamentum arteriosum, just beyond the origin of the left subclavian artery. The sources indicate this region is just prone to stress and tearing due to these physical forces. It's a textbook example of a structural vulnerability created by fixation.
Okay, we've established the origins of the big 3 branches. Now let's detail where this blood is actually heading, starting with the vessel that defines the asymmetry of the whole arterial system.
The brachiocephalic trunk, also sometimes called the innominate artery. It's a critical vessel because it dictates the entire anatomy of the right upper chest.
It's the largest branch from the arch.
It is, and it serves as the sole arterial supplier for the entire right side of the head, the neck, and the right upper limb.
So this single short trunk supplies 2 massive regions, the head and the arm on the right side, whereas the left side gets separate origins for its carotid and subclavian arteries.
The asymmetry is absolute. In terms of dimensions, the trunk is quite short, only about 4 to 5 centimeters in length. It arises from the aortic arch approximately 2.5 centimeters inferior to the jugular notch.
And its course.
It runs superiorly and distinctly to the right adjacent to the trachea.
And its termination is its defining feature. It splits so rapidly, it almost feels less like a trunk and more like a high-speed arterial junction.
That's a good way to think of it. It terminates by dividing into the 2 major right-sided vessels, the right common carotid artery heading for the head and neck, and the right subclavian artery heading for the arm.
And this plit happens pretty high up.
Yes, typically at or just above the superior border of the manubrium, well into the root of the neck.
Let's construct the full 3D map of the brachiocephalic trunk's relations, because it sits smack in the middle of the superior mediastinum. What structures run in front of it?
Anteriorly, in front of the trunk, you have a critical layer of structures. Most prominently, the left brachiocephalic vein runs obliquely across the superior mediastinum, passing directly anterior to the trunk and the origins of the other major arteries.
Okay, so the big left vein crosses right in front.
It does. You also find the thymus gland or its remnants, the manubrium itself, and sometimes the inferior thyroid veins lying anteriorly.
And what about the structures running behind it or alongside it?
Posteriorly, its relations are the trachea, especially in its inferior course, the right vagus nerve, and the right brachiocephalic vein, which runs more laterally.
The distinction is key. The left vein runs anteriorly, crossing the arteries, while the right vein runs laterally and posteriorly to its namesake artery.
An absolutely essential distinction. And here's a nuanced, detailed relationship. The right recurrent laryngeal nerve, the counterpart to the one that hooks under the aortic arch on the left, spirals specifically around the right subclavian artery right as it originates from the trunk.
So the left recurrent laryngeal nerve is vulnerable to aortic arch pathology, but the right recurrent laryngeal nerve is vulnerable to pathology affecting the right subclavian artery or the base of the neck, like a thyroid tumor.
Precisely. The structural relationship is fundamentally different, and it reflects the asymmetry of the arterial system below it. Moreover, the right side of the brachiocephalic trunk itself is in direct contact with the side wall of the trachea, making it a crucial surgical landmark during tracheal procedures.
Okay, focusing now on the common carotids, which are the main upward supply lines to the head and brain. And once again, the asymmetry of their thoracic origins defines their character.
It really does. The difference in origin dictates their entire thoracic trajectory. The right common carotid artery is simply the medial termination of the brachiocephalic trunk, so it's shorter, and it starts lower down in the chest.
But the left is a whole different story.
It is. The left common carotid artery arises directly as the second branch from the aortic arch. This means it has a significant thoracic course, traversing the superior mediastinum before it even enters the neck proper. It is, therefore, the longer of the two.
What's their general course once they ascend, and what key venous structures are they immediately adjacent to?
Both ascend superiorly, running immediately anteromedial. On the right side, this means the common carotid runs anteriorly and medially to the superior part of the right brachiocephalic vein and the superior vena cava.
So the major veins are running alongside and slightly behind the carotid traffic, a very close bundling.
Extremely close.
Let's consider the structures flanking the carotids as they rise through the superior mediastinum. What separates them from the central respiratory and digestive tracts?
Medially, they are separated from the trachea and esophagus. This separation is achieved by a layer of intervening structures, the inferior thyroid veins and the thyrocervical trunk and vertebral arteries, which dive deep into the neck.
And there are some critical nerves medially as well, especially on the left?
Yes. Medially to the left common carotid, you find the left vagus and the left phrenic nerves. But arguably the most important structure running with the left carotid is the thoracic duct.
The major lymphatic return vessel for the entire lower body.
Absolutely. The thoracic duct runs superiorly between the left common carotid artery and the esophagus. This proximity means that in procedures involving the root of the neck or the superior mediastinum, injury to the thoracic duct is a major risk.
Which can result in a chyle leak, a very difficult surgical complication.
It can. This is a detail surgeons must always keep in mind. The journey of the left carotid through the chest is just so much more complex and, frankly, fraught with danger, simply because of its direct origin from the arch and its proximity to that thoracic duct.
Okay, now for the subclavian arteries, heading for the arms.
These are the critical routes to the upper extremities, and just like the carotids, their difference in origin affects their length, their course, and their thoracic relations.
And again, the asymmetry is defined by the brachiocephalic trunk.
That's right. The right subclavian artery arises from the brachiocephalic trunk, while the left subclavian artery arises directly from the aortic arch, which makes it inherently longer as it has to ascend all the way from the arch up toward the neck.
Describe their course, that critical arch they make as they leave the thoracic cavity.
Their course is defined by this massive arc. Both arteries ascend laterally, arching superiorly and posteriorly, passing over the apex of the lung and the pleura. They're essentially running through that narrow channel we call the thoracic inlet.
So they are a landmark for the very top of the lung.
They are. They pass posterior-superiorly to the apex of the lung. Their termination is clean. They pass over the first rib, and at the lateral border of that first rib, they immediately transition and become the axillary artery, beginning their journey into the armpit and the upper limb.
Okay, let's detail their specific relations as they navigate that crowded thoracic inlet. What key structures lie around them?
They lie posterior to several critical structures: the internal thoracic vein, the phrenic nerve, and the origin of the thyrocervical trunk.
And there's a classic anatomical quiz question here about the veins.
There is. The subclavian veins are consistently and reliably positioned anterior to the subclavian arteries.
Vein in front, artery behind. A classic distinction that helps orient anyone working in that incredibly crowded anatomical space.
It does. And what about the specific relation of the longer left subclavian artery, given its farther back origin?
It has a more vertical course, doesn't it?
It does. Because the left subclavian arises farther posteriorly from the aortic arch, it has a significant vertical component to its course. It has to run superiorly first, and then laterally to reach the base of the neck. Our source material makes a specific mention of its very close relationship with the ascending thoracic duct as it begins its neck course, adding yet another layer of complexity to the left side anatomy.
It's just a tight squeeze as all these great vessels negotiate that small space defined by the first rib and the clavicle.
A very tight squeeze.
We've completed the arch, the great traffic distributor. Now we are following the blood flow as it turns downward and heads toward the lower body. This is the descending thoracic aorta, a long vertical pipeline running right down the vertebral column.
This is the continuation of the systemic high-pressure highway, and its journey is one of gradual centralization. It begins at the precise level of the lower border of the fourth thoracic vertebra, T4, the same level where the arch terminates.
And its positioning in the chest changes significantly as it descends, which indicates its shift from the anterior mediastinum to the posterior.
Yes. Initially, it sits squarely in the left posterior mediastinum, running significantly to the left of the vertebral column. But this is a temporary position. As it descends, it gradually crosses the midline, moving medially toward the vertebral column.
So that by the time it reaches the lower thoracic levels, say T8 to T12,
it is often running close to or sometimes exactly on the midline.
And that medial shift allows it to prepare for its exit. Where does this thoracic segment of the aorta officially terminate?
It exits the thorax through the large central opening in the diaphragm known as the aortic hiatus. This passage occurs at the level of the 12th thoracic vertebra, T12, at which point it officially becomes the abdominal aorta.
And its overall length is substantial, making it a primary structural element of the posterior chest wall.
Very much so.
Let's detail its anatomical relations during this long, centralized descent. What structures are immediately anterior to it?
In front of the descending aorta, anteriorly, the primary relations are the esophagus, which is closely intertwined with the aorta, particularly as it shifts position. And then inferiorly, the aorta is also anteriorly related to the pericardium and the diaphragm as it approaches that hiatus.
And what structures flank it laterally during this descent?
The lateral relations are especially important. On the right side, running parallel and alongside the aorta, you have the prominent azygos vein and the crucial thoracic duct.
Okay, azygos vein and thoracic duct on the right.
And on the left side, its main neighbors are the pleura and the left lung itself.
This proximity to the azygos vein and the thoracic duct is vital. It explains why a posterior mediastinal mass can simultaneously compromise arterial, venous, and lymphatic flow.
Absolutely. The azygos and the thoracic duct are effectively running in the ditch alongside the aorta's main road, which makes them really vulnerable to any pathology arising from the aorta itself.
Okay, let's categorize its branches into the two major functional groups, visceral and parietal, supplying organs and walls respectively, starting with the visceral branches, supplying the internal organs.
These are essential for the survival of the thoracic contents. First, you have the bronchial branches. These provide the nutrient blood supply to the lung tissue itself, not the blood being oxygenated that comes from the pulmonary trunk.
And the number varies.
It does. Typically, there are 2 on the left and 1 on the right. Next, we have the esophageal branches, usually 2 or 3 of them, providing continuous blood flow to the middle and lower esophagus.
And finally, smaller branches.
Yes, there are small, variable pericardial and mediastinal branches that supply the pericardium and the surrounding tissues.
And now the parietal branches, which supply the chest wall structure itself.
The majority of the output here is the posterior intercostal arteries. These are 9 pairs of arteries that supply the intercostal spaces from the 3rd to the 11th. They run along the underside of the ribs to supply the muscles, nerves, and skin of the chest wall.
And they form vast networks of anastomosis or
They
connections.
do. Additionally, we have the superior phrenic arteries, which supply the superior surface of the diaphragm, and the subcostal arteries, the lowest pair, running along the inferior border of the 12th ribs.
This incredible network of parietal branches is what gives the descending aorta its critical role in collateral circulation, which we're about to discuss. But first, let's revisit the clinical relevance of this massive descending pipeline.
We have to discuss aortic rupture again. As we noted, it has an extremely high mortality rate, often resulting from blunt trauma deceleration injuries. We need to re-emphasize the biomechanics here.
The most common site for a tear is the proximal aorta, just beyond the ligamentum arteriosum.
Precisely because that fibrous remnant acts as a fixed point, creating a pivot during rapid movement. The kinetic energy attempting to move the relatively mobile arch against the fixed descending segment causes these overwhelming shear forces at that vulnerable junction.
The second major clinical feature involves a narrowing problem, coarctation of the aorta. Let's spend some real time on this because it beautifully illustrates the body's incredible compensatory mechanisms.
Coarctation. It's defined as a localized narrowing. It's a congenital condition usually found close to the ductus arteriosus area. It acts like a bottleneck in the system.
And this bottleneck creates a massive pressure gradient.
A huge one. You get extreme hypertension, high pressure in all the arteries upstream, so the head, neck, and upper limbs. Meanwhile, the pressure in the descending aorta and the lower body is dangerously low.
And it's classified as either preductal, the infantile type, or postductal, the adult type, depending on where the narrowing is relative to the ductus.
Correct. But the body refuses to let the lower half starve of blood. It finds a way around the obstruction. It essentially creates a natural bypass system using those parietal branches we just listed.
The intercostal arteries.
That is the astonishing genius of the circulation. The low pressure downstream effectively recruits pre-existing arterial connections to bypass the obstruction. These connections involve the internal thoracic arteries, which are branches of the subclavian, running down the inside of the sternum.
And they connect with those posterior intercostal arteries, the branches of the descending aorta?
Yes, the flow reverses or dramatically increases through these routes to get blood past the constriction.
And this incredible adaptation has a definitive visible sign that clinicians search for on imaging.
It does. The classic radiological sign is rib notching.
Rib notching.
Due to the massive increased and pulsatile flow through these newly recruited collateral intercostal arteries, they become grossly dilated. I mean, they're literally carrying blood meant for the entire lower body. Over time, the constant pulsation and erosion cause scalloping or notches on the inferior margins of the ribs.
And you can see that clearly on a chest x-ray.
Clearly. That image provides an immediate diagnosis. It is a physical sign of an ongoing, successful, though pathological bypass operation that's been performed entirely by the body itself. It's a remarkable testament to the body's phenomenal redundancy.
And that high vascularity created around the scapula and backed by this network is absolutely crucial for the patient's survival, ensuring just enough pressure reaches the lower body.
It's what keeps them alive.
Okay, we have followed the high-pressure outbound traffic. Now let's shift gears entirely to the low-pressure system handling the massive volume return. We are on the feeder roads leading back to the right atrium.
This requires a different mindset. This is a low-pressure, high-capacitance system. And critically, the anatomical relationships often cross the arterial routes, which is why the asymmetry is so pronounced here.
Let's start with the brachiocephalic veins, which form the main trunk.
These vessels are formed by the union of two great veins at the base of the neck. The internal jugular vein, which drains the head and neck, and the subclavian vein, which drains the upper limb.
And the asymmetry we saw in the arteries is even more extreme here, particularly in their length. Why is the left brachiocephalic vein so much longer?
The sources are very clear on this. The right brachiocephalic vein is quite short, only about 2.5 centimeters long, and it runs almost vertically downward. It's a direct shot toward the SVC.
But the left brachiocephalic vein is massive.
It is. It's about 6 centimeters long, more than double the length of the right side.
Why does the left side take such a scenic route when the right side is a direct shot?
It's forced to. It has to travel across the entire superior mediastinum from left to right to meet the right vein and form the superior vena cava.
So it has this long, oblique course.
It does. It runs obliquely posterior and to the right, crossing the entire superior mediastinum posteriorly to the manubrium, And crucially, as we noted before, it runs superior to the origins of the three major arterial trunks.
The brachiocephalic trunk, the left common carotid, and the left subclavian.
Right over the top of all of them.
So the single longest vein in the superior mediastinum runs horizontally right over the top of the big three arteries. That sounds vulnerable to compression, doesn't it?
It absolutely is. Its length and its horizontal course make it very vulnerable to compression against the manubrium or by nearby tumors, which can lead to significant congestion on the left side of the head, neck, and arm.
Let's list the major tributaries that feed into these two massive but asymmetrical veins.
The shorter right brachiocephalic vein receives the right vertebral vein, the right internal thoracic vein, the right inferior thyroid vein, and sometimes the small thymic and first posterior intercostal veins.
A pretty standard set.
It is, but for the longer left brachiocephalic vein, we see a parallel but more expensive list because of its long course. It gets the left vertebral, left internal thoracic, left inferior thyroid, thymic pericardiophrenik, which drains the pericardium and diaphragm, and the first left posterior intercostal vein.
Once these two asymmetric traffic lanes meet, they form the superior vena cava, the great collector that drains the entire upper body, head, and neck. Give us the dimensions and precise location of this crucial vessel.
The SVC is about 7 centimeters in length and approximately 2 centimeters in diameter. It's formed by the junction of the two brachiocephalic veins behind the lower border of the first right costal cartilage.
And its course.
It then descends vertically with a slight convex curve to the right, sitting right alongside the ascending aorta.
And where does it terminate its vital mission?
It enters the right atrium, the main receiving chamber of the heart, at the superior border of the third costal cartilage.
And its relationship with the heart structure is analogous to the ascending aortas, isn't it? It's partially inside the pericardium.
Yes. The lower half of the SVC is partially enclosed by the serous pericardium, which reflects its immediate and functional relationship to the heart. This means that a large part of the SVC is protected, but it's also subject to the same pressures and movements as the heart itself.
What are its critical thoracic relations? What's running alongside it?
Posteriorly, it's related to the trachea and the right vagus nerve, but most notably, it's related to the arch of the azygos vein. The azygos vein, which runs up the right side of the spine, arches over the root of the right lung to provide this massive input into the SVC just before it enters the heart.
And laterally?
Laterally, running alongside it, we find the right phrenic nerve and the mediastinal pleura.
Now for the serious clinical implication, SVC obstruction syndrome. Why is this so rapidly debilitating for a patient?
SVC obstruction is severe because it blocks the high-volume return from the massive vascular beds of the head, neck, and upper limbs. Since the SVC handles roughly 2/3 of the venous return from the upper body, blocking it just creates this massive backlog of blood.
And it's most often caused by external compression from tumors.
Very often, frequently lung cancer or massive mediastinal lymphadenopathy.
If the blood can't return efficiently, the symptoms must be immediate and dramatic.
They are. The hallmark signs are severe venous distension in the neck and head, facial edema or swelling, and possibly cyanosis, a bluish discoloration, because the venous pressure just skyrockets. This requires immediate diagnosis and treatment, often surgical bypass or radiotherapy, to relieve the external pressure on this very thin-walled vessel.
We must also detail the surprisingly common anatomical variation here. A persistent left SVC. This is important for medical intervention.
It is. This anomaly occurs when the left superior vena cava fails to properly atrophy during embryonic development. Instead of disappearing, it remains as a separate vessel.
So you have two SVCs.
You do. This variant left SVC usually drains most of the left upper body venous return, but it doesn't join the SVC on the right. Instead, it typically drains into the right atrium via the coronary sinus.
What are the functional complications of this variation?
Well, while it's often asymptomatic, it can present major complications during cardiac procedures. Catheterization attempts from the left side can be very difficult, and the entire path through the coronary sinus is unexpected if you're not looking for it. Plus, the presence of a persistent left SVC is often associated with other cardiac anomalies, sometimes including the coarctation we discussed earlier.
Finally, let's take a detailed look at the inferior vena cava's role in the thorax. This vessel carries blood from all tissues below the diaphragm, making it the highest volume venous collector of all.
The IVC is predominantly an abdominal vessel, but its thoracic course, while short, is incredibly vital. It returns blood from all the infradiaphragmatic tissues and has to pass through the diaphragm to reach the heart.
And it does this via its own dedicated opening, the caval foramen, at the level of the 8th thoracic vertebra, T8.
That's right, T8.
I find the location of the caval foramen interesting. It's located in the central tendon of the diaphragm, not the muscular part. Does that positioning have a functional consequence?
It does, and this is a key physiological insight. Because the foramen is in the central tendon, which is a fibrous, relatively immobile part of the diaphragm, the IVC is less constricted by breathing than, say, the aorta or the esophagus, which pass through muscular parts.
So it's protected from the squeezing of respiration.
To a degree, yes. But during deep inspiration, when the diaphragm contracts and flattens, the IVC can be stretched slightly, which actually aids venous return to the right atrium, a mechanism often referred to as the thoracic pump.
Does it receive major drainage just before entering the heart?
It does. The hepatic veins, which drain the massive volume of blood from the liver, enter the IVC just before it passes through the pericardial reflection to enter the right atrium, typically around the T5 level. This makes the segment passing through the liver and diaphragm a high-risk area for compression or obstruction.
And thinking back to the survival mechanism of coarctation, we established that the body has massive redundancy for arterial flow. Does the venous system have a similar robust backup system for the vena cava?
Absolutely. If we connect this to the bigger picture of circulatory compensation, in cases of severe obstruction to either the SVC or the IVC, the body relies heavily on the azygos system. The azygos and hemizygos veins, those parallel venous trunks running alongside the spine, provide a massive collateral circulation route. They connect the superior and inferior venous territories.
So if the IVC is blocked on the abdomen, the blood can divert into the ascending lumbar veins, into the azygos system, travel up the side of the spine, arch over the right lung, and dump into the SVC. It's a complete venous bypass.
It is the body's major trunk road bypass. We also see collateral circulation via the vertebral venous plexuses and connections between the common iliac vein and other systemic veins. This redundancy is what allows patients to survive, sometimes for decades, with chronic venous obstruction. It demonstrates the incredible adaptability of the low-pressure system.
This has been an incredibly detailed and I think necessary journey through the anatomical chaos of the thoracic traffic lanes. Let's quickly recap the biggest takeaways that should fundamentally alter the way you, the learner, view this region.
I think the primary takeaway has to be the theme of asymmetry. The entire arterial landscape is defined by the brachiocephalic trunk, which makes the right side significantly different from the left in terms of origin, length, and nerve relations, especially that recurrent laryngeal nerve loop.
And the same asymmetry on the venous side.
Even more so, the venous architecture is defined by that massive 6-centimeter left brachiocephalic vein, taking the long, vulnerable route across the mediastinum to meet the short, direct right brachiocephalic vein.
Second takeaway. Mastering the precise location of the aortic arch relative to the T4-T5 thoracic plane is the non-negotiable anchor point for all of thoracic anatomy. That small space is where the entire circulatory system pivots.
And third, the synthesis required to truly understand these vessels is that they are not isolated tubes. They are functionally and pathologically defined entirely by their immediate neighbors. Understanding the why the left recurrent laryngeal nerve hooks under the aorta, why the ligamentum arteriosum creates a lethal shear point in trauma, or why coarctation creates collateral bypasses visible as rib notching, is far more valuable than simply memorizing the dimensions of a vessel.
So what does this highly detailed map of the great vessels mean for the learner, for you listening right now?
It means you now have the necessary foundation for advanced learning. You can now approach cardiac imaging, surgical descriptions, and complex thoracic pathologies with a much more intuitive understanding of the 3D relationships. It allows for quicker, more accurate processing of clinical information. It's the map you need to navigate the chest effectively and confidently.
Here's where it gets really interesting as a final thought. Building on the congenital variations we discussed, like the double aortic arch and the persistent left SVC, we mentioned that despite our reliance on textbook standardization, human anatomy has wide and surprising variation.
And that raises an important question. If the failure of one small embryonic structure, like the left SVC, can lead to a potentially complicating anatomical variant that we see in the adult, what other commonly accepted anatomical norms might be masking clinically significant variations that we rarely, if ever, screen for?
That's a great point. For instance, considering how common the bovine arch is, what percentage of the general population might have other less common aortic or venous anomalies without ever knowing it.
Exactly. And what are the implications when they finally need an invasive cardiac procedure, where a slight deviation in the vessel trajectory or branching pattern can turn a routine operation into a complex crisis?
It's a profound reminder that when dealing with human life, the standard blueprint is just a guide. The map of the individual chest always requires confirmation.
Anatomical variation is not just a footnote, it is a critical variable in medicine.